welcome to The Generalist. Today we are covering another of the CCFP 105 topics, dyspepsia. This episode was written by myself, Chris Cochrane, and reviewed by Sarah Donnelly. My co-host today is Caleb Dusdall.
Hiya! There's only 3 objectives for this episode, and we're going to combine numbers 1 and 2. The Canadian Association of Gastroenterology has guidelines for dyspepsia, which we will link to and which we leaned on quite a bit for this episode.
CAG, or the Canadian Association of Gastroenterology, has definitions for dyspepsia, and that is predominant epigastric pain lasting at least 1 month. This can be associated with any other upper gastrointestinal symptom, such as epigastric fullness, nausea, vomiting, heartburn, provided the epigastric pain is the patient's primary concern.
Off we go. Objective 1. In a patient presenting with dyspepsia, include cardiovascular disease in the differential diagnosis. And Objective 2. Attempt to differentiate by history and physical exam between conditions presenting with dyspepsia, as the plans for investigation and management may be very different.
To paraphrase the CAG definitions, dyspepsia describes the broad category of upper GI syndromes accompanied by symptoms of gnawing or burning epigastric pain, and may or may not include bloating, nausea, vomiting, burping, or regurgitation of food or stomach acid. Essentially, it sounds like an undifferentiated upper GI complaint.
Unfortunately, there is overlap in symptoms with other conditions that are not gastrointestinal in nature.
Our goal is to rule out the potentially serious causes and to hopefully determine a diagnosis so we can treat it. The AAFP has an article on dyspepsia that outlines the possible GI causes. We will use this to guide our differential and go over how we might rule them in or out on our history and physical.
Also, we're going to assume that for every patient that we're going to get a reasonable history, including the OPQRS-TAAA or whichever mnemonic you use. And we're going to focus on some of the more specific points that you should inquire about.
First up, ACS, or acute coronary syndromes.
As the objectives indicate, we cannot miss ACS. Whether you're in a clinic or the ED, this is a biggie.
Although we talked about acute coronary syndrome extensively in the chest pain episodes, we will include a couple of the highlights to ask about when taking your history for an epigastric or thoracic pain. Keep in mind the symptoms of ACS are quite variable between patients, including the location and nature of the pain and the associated symptoms like nausea.
The following points on history all have likelihood ratios of about 2 in favor of ACS as the diagnosis.
Ask about cardiac history and risk factors, including abnormal stress test or peripheral artery disease.
Ask if their symptoms are associated with exertion.
Ask about radiation to bilateral jaw or arms.
Ask about a change in symptoms in the past 24 hours.
Your physical should include a cardiac exam, but we're not likely to find much in either a GI syndrome or an ACS. Instead, getting an ECG and troponin should be top priority if there is any concern this may be cardiac.
And if you think it's ACS and you're in the clinic, get them out of there. Call 911.
Always good advice. Next up is our pulmonary and other cardiac causes. I couldn't find a lot of information pointing to pulmonary or other cardiac causes as part of the differential for dyspepsia, but it's worth thinking about since the main symptom of dyspepsia is epigastric discomfort.
So be sure to rule out pneumonia or pulmonary empyema, as well as pericarditis. All of these can have similar lower down chest pain. Ask about fever, cough, shortness of breath, and positional changes.
Physical exam, including auscultation of the lungs and heart, is probably more relevant, as you may hear changes in breath sounds or a classic rub. Getting a chest x-ray or ECG can, of course, be useful.
Now into the gastrointestinal causes. The majority of these patients will fall into the category of functional dyspepsia. Functional dyspepsia means that no definite structural or biochemical cause can be identified for their symptoms. However, that implies that a thorough workup has been completed. In practice, we're going to treat patients empirically if there are no red flags. Thus, a cause might not ever be identified. We'll go through an algorithm for management a bit later.
Of those with a discernible cause, peptic ulcers make up the largest portion. Here, ask about a personal or strong family history of ulcers, melena, smoking, or alcohol use. Also inquire about medications and herbal substances, which we'll go over a little bit later.
For these GI etiologies for dyspepsia, a physical exam could reveal epigastric tenderness or melena on a DRE, and there might be anemia on the blood work.
Investigations can include tests for H. pylori or endoscopy, depending on the presentation and level of concern. And as we said, we'll go over this shortly.
The next most common GI cause of dyspepsia is gastroesophageal reflux disease, GERD.
Does the patient complain of heartburn or sour belches?
Are the symptoms worse when the patient is lying down?
Does the patient have a chronic cough or hoarseness? Well done.
The physical and lab work should be pretty normal with this.
Next up, gastric or esophageal cancer, which makes up 1 to 2% of dyspepsia complaints, especially in those over 50. Ask about recent significant weight loss,
Trouble swallowing,
recent protracted vomiting,
history of melena,
smoking,
alcohol use,
and hot beverages or pickled vegetables.
Also ask about a change in weight, painless jaundice, or a mass in the abdomen.
Moving on, somewhat less commonly presenting with just dyspepsia is biliary tract disease. Here we want to ask about any history of jaundice, dark urine, or pain occurring after meals or associated with meals or belching.
In this case, there can be right upper quadrant or epigastric tenderness, and there might be a positive Murphy sign. You might also notice some jaundice. Investigations may reveal altered liver enzymes and bilirubin or indications of an infection.
Continuing down our list into the less common causes, we get to pancreatitis. Ask, is the pain stabbing and does it radiate to the back?
Is the pain abrupt, unbearable in severity, and does it last many hours without any relief?
Ask, is there a history of heavy alcohol use or any of the other 11 causes of pancreatitis, like triglycerides, biliary disease, and of course, scorpion stings, the most important one to rule out.
I see it every day. Next item to consider on your differential gastrointestinal for dyspepsia is irritable bowel syndrome. Is this dyspepsia associated with an increase in stool frequency?
Is pain relieved by defecation?
Next category is metabolic disorders. Does your patient have a medical history of diabetes, hypo or hyperthyroidism, or hyperparathyroidism?
Do they have risk factors for hypercalcemia, like cancer or bone metastases?
Also consider digestion and malabsorption issues like celiac or lactose intolerance.
Here, ask about timing and association with types of foods.
And there's also a boatload of medications that could be contributing to your patient's dyspepsia.
The big ones here include NSAIDs and COX inhibitors.
Alcohol or caffeine can contribute.
And then the other possible causes, which we're going to read through really quickly: acarbose, alendronate, cisapride, codeine, iron, metformin, oral antibiotics, orlistat, potassium, corticosteroids, and theophylline.
Man, a number of herbs are also noted to cause or contribute to dyspepsia. Some of these are garlic, ginkgo, saw palmetto, feverfew, chaste treeberry, I presume I said that right, and white willow.
Beautiful.
And there's a table, which I think is from the AAFP article referenced. If you want to refer back to that, you'll see that 4 of these are really common, and then the rest are considered rare. So lock in the first 4 and grab a few of those more rare ones to keep in mind. Oh, that's the end.
That's the end of objectives 1 and 2.
Objective 3. In a patient presenting with dyspepsia, ask about and examine the patient for worrisome signs and symptoms.
The red flags to watch out for when a patient complains of dyspepsia include clinically significant or unintentional weight loss, usually greater than 5% body weight over 6 to 12 months,
overt gastrointestinal bleeding,
or the presence of alarm features or a rapid progression from previous of any of
dysphagia,
odynophagia,
unexplained iron deficiency anemia,
persistent vomiting,
palpable mass or lymphadenopathy,
a family history of upper gastrointestinal cancer.
Right, we've covered the differential for dyspepsia, including ACS as a mimic, and the big GI causes, peptic ulcers, GERD, and cancer. We also talked about the red flags just now that we need to watch out for. But what do we do once we have our history and physical done?
Surprisingly, the objectives don't cover this, but we're going to include it anyway.
Because we're for you. We're doing this for the people, huh?
Above and beyond.
Above and beyond.
The primary investigations we have in our toolbox are endoscopy, testing for H. pylori, and empiric therapy with a PPI.
To answer the question of what investigations when, we're going to look to an algorithm included in the CAG guidelines for dyspepsia, and screenshots of their pathway are also included in the show notes, so go there, thegeneralist.ca.
If the patient has any of those red flags we talked about, or if they are over 60, they should be referred for endoscopy. The timing for this is not specified and will likely depend on your specialist or how concerned you are about this patient and how much you advocate for them.
Based on the endoscopy, if there's a specific disease process or finding, treat it.
It's that simple. Otherwise, if the endoscopy is relatively normal, or if there's no endoscopy performed because they're young or non-concerning, then testing for H. pylori is suggested.
If H. pylori is present, treat it with your 4 agents. Typically, this is a PPI, bismuth, clarithromycin, and metronidazole. We've attached a small table from the AHS pathway for H. pylori treatment based on the CAG recommendations. One is they're both quads. I don't know. Look at them. They're there.
All right. And then test for eradication of H. pylori at least 4 weeks after antibiotics are completed, and at least 3 days without a PPI. But ideally hold the PPI for 2 weeks before testing for eradication.
If H. pylori is not present, then a 4 to 8 week trial of a PPI is suggested.
If symptoms are present but improved, then continue for 6 months.
If the symptoms persist and there's no new concerning features, the CAG actually suggests a trial of tricyclic antidepressants and or prokinetic, this is kind of new to me. I didn't know that until this episode. If there's still no response to either of these, they actually recommend psychotherapy at this juncture.
If all that fails or things get worse, you can always refer for an endoscopy.
Ta-da!
Right back to the beginning of your algorithm.
All right. Let's quickly talk about PPIs. The main one that we use all the time is pantoprazole probably, but there are others, some of which are over the counter, including lansoprazole, esomeprazole, and omeprazole.
All the PPIs seem to be safe in pregnancy and breastfeeding, but pantoprazole has been fairly extensively studied, and no dosing changes need to be made.
Nice. The typical dosing is 40 milligrams PO once daily, ideally 30 minutes before breakfast, ensuring your patient is timing their dose correctly before trying the next line of treatment. A dosing of 20 milligrams per day is also an option, but in practice, I don't think either of us have seen that actually used. It might be worth a try, I guess.
With suspected upper GI bleeds, we go the IV route with a loading dose of 80 milligrams, followed by an infusion of 8 milligrams per hour, though this may differ based on your site and your specialist preference. Of note, a systematic review/meta-analysis from 2014 showed non-inferiority when comparing pantoprazole 40 milligrams IV BID to pantoprazole infusion. That said, essentially every center I've worked in is very attached to the panto infusion still.
Hear, hear, hear. And that's it. Beautiful. Tight.
That covers dyspepsia.
Love it.
Have a look at the show notes if you want to review those. The algorithms are included there as well as the table of causes.
Chris, crushing it with another beautiful episode. Sarah, swooping in with the review. There's tons of show notes left to do. There's tons of art. There's tons of infographics if that is something that tickles your fancy. If you want to make episodes, write episodes, do research, offer support. If you're good at building websites or, I don't know, man, bring your talents our way. We love you.
Yeah. Thank you, everyone, for your feedback and support.
Bye.
See ya.